All right, if you're just hopping on, just a couple more minutes before we get started. We have a few more folks we're expecting to join us this evening. Okay, well, thank you all for joining. Just want to let you all know that there will be a live Q&A after the presentation. So please feel free to submit your questions through the question and answers. We will open up the webinar to the Q&A at the conclusion of our presentation. And your questions will go directly to the panel. Participants will not be able to view your questions, so don't be shy, ask away. So right now we're gonna go ahead and get started. Welcome everyone. Today we're here to learn about an important topic, the latest techniques to solve knee and hip pain. My name is Felicia Fontaine and I am the Senior Director of Operations for Sturdy Health. Thank you so much for being here. Now, whether you're seeking to enhance your knowledge or support a loved one or be proactive about your own health, this webinar is for you. Your participation and engagement are welcomed. We do have that poll screen that I mentioned that we'd love for you to fill out just to share a little bit about why you're here today. And again, as I mentioned, there will be that question and answer segment at the end of the presentation. So this is your opportunity. Ask your questions. The rest of the group will not be able to see your questions. They're submitted just to our panel. Don't be shy. Our panel is here to help and very excited to hear from you. So today's panel includes two exceptional Sturdy Health doctors. We have Dr. Andrew Porter. He's an orthopedic surgeon specializing in joint reconstruction at Sturdy Health Orthopedics and Sports Medicine, right here in Attleboro, Massachusetts. Dr. Porter earned his Doctor of Medicine at Temple University School of Medicine in Philadelphia, PA. He received his Bachelor of Arts in Biology with a minor in Spanish literature from Boston University. Dr. Porter completed a fellowship in trauma and complex adult reconstruction at the New Jersey Medical Center and completed his residency in orthopedic surgery at Temple University Hospital in Philadelphia, Pennsylvania. Now, in addition to his practice, Dr. Porter remains active as a researcher, as a reviewer for the Journal of American Association of Orthopedic Surgeons and the Orthopedic Trauma Association International. He has also actively worked on designs and reviewed the work of the Temple University Engineering Department, Beth Israel Deaconess Medical Center, the Harvard Medical School, and the Boston University School of Medicine Research Lab. We also have joining us Dr. Saul Magitsky, who is an orthopedic surgeon, a colleague of Dr. Porter at the Sturdy Health Orthopedic and Sports Medicine here in Attleboro. Dr. Magitsky received his Doctor of Medicine from Mount Sinai School of Medicine and completed his residency at Kingsbrook Jewish Medical Center. He completed his training at Rush University Medical Center with a fellowship in adult joint reconstruction. Dr. Magitsky specializes in all facets of musculoskeletal hip and knee problems. He offers the Smart Knee implant surgery using the Persona IQ Smart Knee, which captures patient-specific gait and range of motion metrics during post-surgery patient monitoring to ensure recovery is on track and optimized. Dr. Magitsky utilizes arthroscopic and other minimally invasive surgical techniques to minimize the impact and underlying issues for muscles and tendons, allowing faster recovery with significantly less pain. So now, without further ado, I'm going to turn it over to Dr. Porter to take it away.
Great. Thanks, Felicia. So first and foremost, thank you all for joining. I hope you find this talk helpful. And thank you too for our team here at Sturdy Health for putting this all together. So today we're going to focus primarily on knee replacements and some of the technology that both myself and Dr. Magitsky are using here at Sturdy Health. But I will say both him and I also do perform hip replacements here and treat conditions involving the hip, including hip arthritis. But again, the talk today is going to focus primarily on knee replacements and some of the newer technology that we're using here at Sturdy. So first, I'm going to kind of go over a broad overview of understanding joint pain, what can contribute and cause arthritis, non-surgical treatment options. Then we'll go on, and both myself and Dr. Magitsky will discuss the technology we're using in our joint replacement surgery procedures. Then we'll go on to talk about recovery expectations, what you can expect to get back to, and we'll open up for a Q&A at the end here. So what causes joint pain? And in this talk too, I'm going to focus primarily on arthritis. There are certainly many causes of knee pain, but as we get older, the cartilage does start to wear and thin away to some degree in the knee. The most common cause of this is just that. Just over time, the cartilage does start to wear away. This is referred to as osteoarthritis, and this is the most common cause of degenerative changes in the knee. There are other causes. Rheumatoid arthritis refers to an inflammatory condition in which a person's immune system attacks the cartilage in their knees, hips, other joints as well. And there's also post-traumatic arthritis. So this refers to if you've had an injury in the past, potentially had surgery in the past that causes the knee to degenerate a little bit faster than it would otherwise. Next slide, please. So treatment options. So we always try to exhaust non-surgical treatment options before going on and discussing any type of surgical interventions, including knee replacement. So non-surgical treatment options include a walking aid, a cane or a walker. This helps both to offload the painful joint to some degree, as well as provide some additional stability to prevent any falls or any which can contribute to further injuries. Heat and cold therapy can be helpful. Physical therapy, where we're working on strengthening the muscles around the knee, building some flexibility, and working through some of the stiffness that can come with arthritis. Patients find that helpful as well. Then over-the-counter medications, including Motrin, Aleve, ibuprofen, Advil, Tylenol. Some of those can decrease some of the inflammation and irritation in the knee, which gives patients some pain relief. There's also the possibility of doing corticosteroid injections into the knee. It doesn't treat the underlying arthritis, but it does decrease the inflammation in the knee and gives the patients pain relief. So when to consider joint replacement. So again, we try non-surgical options first because the goal of anything, whether it's surgery or no surgery, is to give you a relatively pain-free and functional knee, something that you can depend upon and it's not at the back of your mind or in some cases the forefront of your mind constantly. So after you've tried some of these other non-surgical treatment options and it gets to the point where that knee pain starts to really interfere with your ability to do the things you want to do, is starting to affect your quality of life, that's the time to consider a joint replacement. So just some overview and background anatomy of the knee. So the knee's primarily made up of three bones. You have the femur, which is the upper thigh bone. You have the tibia down below, which is the main shin bone. Then you also have your kneecap, which we refer to as the patella. On the sides, there are collateral ligaments. And on the inside, there's a meniscus as well as two cruciate ligaments. So there are several types of knee replacements. In this talk, we're going to focus primarily on a total knee replacement, which is the image you see here on the left. There are also partial knee replacements that, again, both Dr. Magitsky and I do perform here at Sturdy Health, but these are a little less common, and I will touch base on those in a minute here. But what the talk's mostly going to focus on is the total knee replacement. So here I just have a quick video kind of overviewing what it involved, on a big picture, from a big picture standpoint in a knee replacement. So in a knee replacement, the knee flexes and extends. There are also some pivot motion involved there too. When a knee replacement, we go in, we cut out the arthritic ends of the bone, we put a metal cap on the femur, we put a metal cap on the tibia, and we put a plastic piece in between. We keep your own collateral ligaments on the side that provide the stability of the knee. This then allows the knee to flex and extend without that catching and crunching you may feel with arthritis, as well as decrease the patient's pain. So it's really can be considered more of a resurfacing procedure, if you will, rather than a full knee replacement. So to touch again on the partial knee replacement, so the knee was divided up into three different compartments. We have the inner compartment, the outer compartment, as well as the compartment underneath the kneecap. We can, in certain circumstances, do a partial knee replacement. Patients who are candidates for this have arthritis isolated solely to one of those compartments. So, on the bottom screen, on the bottom part of that image there, you can see medial, which is the inner aspect of the knee, lateral, which is the outer aspect of the knee, and patellofemoral, which is underneath the kneecap. So these partial knee replacements, some patients say it feels a little bit more like a natural knee, and sometimes the recovery can be a little quicker. But again, these are really reserved for specific patients and with isolated arthritis, really to one part of the knee. So it's much less common than a complete knee replacement. So what I'm going to talk to you about today are the implants and the platform that I use to perform my knee replacements. I use an implant company called Stryker, and I use the Mako robot to perform my knee replacements. The Stryker knee replacement is the triathlon. It's been on the market for almost 20 years, and it has excellent results. In addition to using the Stryker implants, I also use something called the Mako robot to perform my knee replacement surgery. So we'll have a video coming up in a second to get kind of an in-depth look at it. But from a bird's eye view, it begins with a CT scan. I get a CT scan of the knee a couple weeks prior to surgery. This allows me to use some of the software that we have to plan the patient's knee replacement. Not only the size, but more importantly, really kind of dial in that position that implant's going to sit in the patient's knee to a half a degree to half a millimeter. So it's extremely accurate. After we've done the planning, we get into the operating room. I do my standard approach. I then register the knee. I make some final adjustments, and then a robotic arm comes into the field and executes that plan to, again, an extremely high degree of sensitivity. I'm able to dial in the component positions to within half a millimeter, within half a degree, which is something you just can't do with the naked eye. So what's the benefit of having a robotic knee replacement? So there's been a number of studies on this, and they've shown pretty clearly that for Mako, the total knee replacement, where, again, as I mentioned, able to execute the surgical plan to an extreme degree of precision. It protects soft tissues and ligaments from damage, so the robotic arm will not let me resect any more bone than we've planned to. Will also protect the collateral ligaments and the nerves, vessels in the back of the knee as well. I couldn't cut them if I tried with using the robotic arm. Which all of this results in patients having a little less pain postoperatively. They're consuming less narcotic pain medication postoperatively, and therefore it allows them to work with therapy a little bit more aggressively because they're in less discomfort. And I'll say just anecdotally, I've noted since I've started this program here at Sturdy, when I've been doing it here for about a year and a half, patients come in with a little bit better motion at that first 2-week visit. Again, because they're in a little less pain and they're able to push a little bit more with physical therapy. From a partial knee standpoint, again, the robot can be used to perform partial knee replacements as well, and I use it as such. It's more accurate bone removal, which can result in improved outcomes and functioning of the knee. Less pain, again, less narcotic pain medication that patients are requiring, and patients are just reporting that they're in less pain. This results in people being able to work a little more aggressively with physical therapy, resulting in shorter hospital stays and quicker recovery. There's also a platform for robotic hip replacements. I don't perform them too often here, certainly can upon request. I am extremely comfortable with it. And the robotic hip replacements have shown to have more accurate placement and alignment of the hip implants based on the plan that we come up with. The patients report feeling like it's a bit more of a natural hip. There's a reduced risk of dislocation, reduced blood loss, and a greater preservation of bone, which the preservation of bone, this spans all three, the total knee replacement, the partial knee replacement, the total hip replacement. That's important because as joint surgeons, we're always worried about the next procedure potentially. The goal in the vast majority of our cases is that these implants will last you for the rest of your life. But in occasions where the components wear out or something breaks or fractures around the implant and we have to go back in and revise that surgery and that joint replacement we perform, we want to have as much bone left as possible to work with. So bone preservation is extremely important in joint replacement surgery. So as far as the Mako robotic platform, this data is a couple years old, so it's been on the market, this robotic arm-assisted surgery for over 17 years. There have been well over 1 million of these procedures performed. This platform and these instruments and this robot are present in every state and in 35 countries worldwide. They're in the vast, a large number of surgery centers as well as hospitals and academic centers. So here's a quick video kind of going into the intricacies of how what goes into a robotic knee replacement. So it begins with a CT scan. I get a CT scan preoperatively. This allows me to identify the patient's unique anatomy. And I take the CT scan, I run it through the software we have, and myself and my team then are able to come up with a plan to exactly where and how we want to position the knee. The CT scan creates kind of a 3D virtual model, which on the computer looks like this. Then my team and I are dialing exactly where we want to position the knee, again, with an extreme degree of precision, up to a 0.5 millimeter and a 0.5 degree. We review this plan preoperatively. Then we bring the patient back to the operating room. Intraoperatively, I'm taking a small probe and I'm registering the patient's bone intraoperatively to confirm that the knee in front of me right now is the same knee that we have the CT scan of, and that the CT scan is still accurate. This is also why we do need to get the CT scans no more than 3 months prior to surgery, because otherwise the arthritis can progress to some degree, and there's the chance that intraoperatively the knee is not, the Mako robot's not registering that knee. I then intraoperatively, I take it through a range of motion and I pose it in several positions. This allows me to fine tune my plan. And then once we're finalized, this robotic cutting arm comes into the field. I'm holding it at the handle there and guiding it. But again, there's some boundaries there that you see on this screen here that I can't go past. So again, it's impossible for me to damage any of the surrounding soft tissues. And it's also only resects the exact amount of bone that we've planned in our preoperative plan. After that, we again put that metal cap on the femur, a metal cap on the tibia, a plastic piece in between. Then we're closing everything up and taking the patients back to the recovery room. Next slide, please. So after surgery, I put all of my stitches under the skin, so you'll never see any stitches or staples, nothing that needs to be removed. They're all dissolvable. I put a dressing over the top that's waterproof, so you can shower with it. No swimming, tub bath, submerging the incision, anything like that. An hour or two after surgery, I get you up walking around with our physical therapy team. A lot of my patients even go home the same day. At most, keep you one end in the hospital, get you home the following day. Those first few weeks, I have nurses and therapists come to the house, so you don't have to leave for those types of appointments. I see you back in the office 2 weeks after surgery. We're taking that dressing down. At that point, generally, I'm transitioning it to outpatient therapy, just because there's some more equipment and things that they can do at the facility as opposed to in the home. In total, it's about 3 months of physical therapy after surgery. Long term, I let my patients get back to doing whatever they want to do. I have patients that ski, play basketball, martial arts, golfing, all of the above. Activity limitations. So there are some activities, such as running and high impact sports that I'll say I don't prohibit, I discourage. It's because these high impact and repetitive impact activities can potentially wear through the components a little bit faster. But at the same time, there are some patients that, the reason they get out of bed in the morning is for that morning run, and that's not something I want to take away from you. So I would, while I do encourage people to try something, such as biking, cycling, elliptical, swimming, some of that lower impact activities, if running's what you really enjoy doing for exercise, you certainly still can do it with the knowledge that potentially you will wear through the components a little bit faster than you would otherwise. The components I use have an excellent track record. They last upwards of 25 years, potentially much longer than that. So as I said, every time, the vast majority of times, I should say, that we're putting these implants in, we do hope and expect them to last for the entirety of a patient's life. That's all I have, so I'm going to turn it over to my partner, Dr. Magitsky.
Hello, can everybody hear me?
You sound
See
good.
me? Thank you. All right, very good. Guess just waiting to see myself. No video of me. Okay, it's okay. Uh, I can be Felicia. Do
Yeah, I feel like
you see me?
I can see you, so I feel like the
Okay.
participants can see you, and we see your slides, so I think you're good.
Okay, very good. Good evening, everyone. Again, thank you to Felicia and the Sturdy organization for putting this on. It's a really wonderful community informational center. I wanted to thank everybody who's logged on to be here. I want to talk to you tonight about something that has generally changed the way I take care of my patients after knee replacement surgery. I've been taking care of the folks in this community for about 20 years doing knee replacements. So for me to find something and incorporate into my practice that I think makes a huge difference is not something I take lightly. I'm talking about specifically the PIQ Smart Knee System. In knee replacement surgery, we've made tremendous advances in the operating room. But what has always frustrated me as a surgeon over the last 20 years is that once the patient left the hospital and went home, I was essentially flying blind. The first follow-up appointment is typically several weeks later, and in that window, which is the most critical period of recovery, if something was going wrong, I had no real way of knowing. A patient might be struggling with pain, not moving enough, or heading towards a complication, but I couldn't see any of it until they came through my office door at the follow-up appointment, and by then, we had already lost some valuable time. Think about it this way. Um, NASA Mission Control. When astronauts go to space, the ground team isn't just waving goodbye at launch and hoping for the best. They're monitoring every vital sign, every system reading in real time, ready to act the moment something looks off. Until now, recovering from a knee replacement surgery has never had anything like that. Patients went home, and I was essentially waiting for the next office visit to find out how things were going. I felt a bit like a air traffic controller who could only communicate with the plane at takeoff and landing, but had no radar contact in between. Now, you've heard about the robotic surgery systems. These are tools that help us to make more precise cuts during the operation itself, and they're useful. But the PIQ Smart Knee system is something fundamentally different. The Smart Knee system is not about what happens in the operating room, it's about what happens after you go home. Next slide, please. Next slide, please. Thank you. So built directly into the knee replacement components is a small accelerometer, which essentially is a motion sensor with a battery that never needs to come out or be replaced. You don't wear anything extra. It's simply part of the implant itself. And you can see the diagram to the left here, how it's in the little keel that's on the bottom part of that component. Next slide, please. From inside the knee, it continuously records and reports how your recovery is progressing. It monitors your gait, your step count, your activity level, the range of motion all day, every day. The data is transmitted securely to me and my team every morning. Next slide, please. Then when I sit down on my computer, I don't see just one snapshot at a time. I see a graph. I see a continuous picture of how your recovery is progressing day by day. Think of it like a built-in fitness tracker, but instead of just counting steps for your own curiosity, the data is coming directly to me and my team so we can act on it. Here's what this means in practice. If your recovery is going beautifully, the graphs on the left, I can see that on the chart with your function improving steadily each day. That's incredibly reassuring for both of us. You feel confident, I feel confident, nothing needs to be changed. But if you notice your activity suddenly drops off after surgery, and I can see that on the graphs on the right, or your walking pattern changes in a way that concerns me, I catch that immediately every morning. And that means I can intervene. I can reach out before it becomes a real problem. before you were in crisis, before we lost critical recovery time. I can speak to your therapist, recommend more or different exercise regimen, or have you come to the office early for me to evaluate you and determine what's going on. We went from having one data point every few weeks to having data every single day. That is a complete transformation of how I care for you. It's a difference between a physician who sees you once a month and a physician who is quietly, attentively checking in on you every single morning. Knee replacement surgery has a very high success rate. I mean, I've been in this community for 20 years doing these procedures, and maybe have taken care of some of you or even your family members. And most of my patients do wonderfully. But surgery is only half the story. Recovery is the other half. It's a 50-50 effort. The other half, the recovery half, historically happened outside of the surgeon's window. The smart knee system gives me the visibility where I was once blind. It allows me to take care of you better, not just in the operating room, but throughout the entire recovery journey. For my patients, that means fewer surprises, faster identification of issues which may occur, and ultimately, better outcomes for my patients. Next slide, please. For my patients, I'm generally excited about what this technology that I have incorporated into my practice allows me to do, how it allows me to monitor people and intervene when I need to. I have tried to keep it brief, as Dr. Porter has outlined most of the disease process for you already. So I'm happy to take any questions about the smart knee.
All right. Thank you, Dr. Magitsky. Appreciate that. All right. So I think we are ready to move into our question and answer portion of our presentation. I definitely want to thank you both. That was very informative, and really exciting to hear about all the different options that we have for our patients in our community. So let me pull up our first question. So one of our attendees would be curious to know, what is your opinion on non-surgical treatments that they might hear about on the radio or TV regarding regenerative medicine, like prolotherapy or QC?
Yeah, Dr. Magitsky, you want to take this? You want me to talk about this?
I can start off with prolotherapy. Prolotherapy has kind of been around for a while. It's had an on and off opinion in the medical circles. It's basically multi-point injections to cause microinflammation in the tissues, with the idea that then the microinflammation, since inflammation is part of the healing process, can then improve the function by healing the overall area that was injected. Honestly, I have kind of mixed opinions on it. Anecdotally, some people say, that it helps them. Fundamentally, especially in this kind of a disease process, microinflammation or inflammation in general is what causes your pain, dysfunction, and swelling. Microinflammation caused by these injections are not going to regenerate the cartilage. They're not going to return normal function. It may, in some individuals, decrease the level of discomfort you may feel for a period of time, but since it's a mechanical problem, fundamentally, you need a mechanical solution. And prolotherapy will not achieve that for you. Similarly to, as I like to tell my patients, you know what I mean? Arthritis is like losing the rubber off your tire. You can't grow more rubber, on the tire. You can't glue more rubber on. You know what I mean? You need a new tire. And prolotherapy, I guess I would equate it to adding more air in the tire just to get you down the road a little bit. But underlying problem will not be solved. Drew, if you want to address the QC.
Yeah, I certainly agree with all those thoughts and sentiments in it. I'll just reiterate too that once the cartilage is gone, it's gone. Unfortunately, we can't regrow cartilage. We can't turn back time. There's some of the QC kinetics and some of the injections you may have heard about, such as PRP and other injections that claim to regenerate the knee or regrow some tissue, cartilage equivalent. Maybe in very mild cases of arthritis or very early arthritis, but once you have significant arthritis, really to the point you're seeing it on X-ray, there's isn't a lot of hope of regrowing any of that cartilage. I mean, to speak on PRP just for a second too, there are places out there, that so PRP is not covered by insurance, so it's an out-of-pocket cost. There are places out there that will charge you an exorbitant amount for these PRP injections. If it's something that you're really interested in, wanting to discuss further, certainly can come to our office. I do have a partner here, Dr. DeCola, who does perform PRP injections at essentially the cost that the kit costs us. So we're not upcharging this, because you can go to some places, and I've had patients tell me they've paid $10,000 for a PRP injection. So whatever you want to do, we're certainly happy to go down that path with you. But I would recommend steering you away from people that are going to, charge you those types of costs.
All right, we've got another question, Dr. Porter. I think this one would be steered towards you. So, I am 84 and a candidate for full knee replacement. I was told by another surgeon that robotic surgery requires a larger incision and the surgery is longer. What would be your response and the reasons for that? Thank you.
Yeah, it's a great question. So I'll say, as far as incision goes, my incision isn't any larger than it is for if I was to do the surgery manually, and I certainly still perform knee replacements without the robot. Yeah, and so I've gotten my technique down so that my incision isn't really any longer at all. And I do, may have friends who have had knee replacements. I do put some pins in the bone during surgery. I do them all through the same incision too. There are some surgeons who will make extra incisions outside of that one main incision. I go right through the incision I have, and really don't have to extend it at all. As far as time goes, I don't see any increase in time. If in fact my time may be even lower using the robot now. I generally have my implants in within 25 to 35 minutes. So a day, the whole process takes a little bit longer, because then we have to close everything. It would get you in and out of the OR, but the whole procedure, it does not add any time at all, for at least in my hands, and in fact probably decreases time.
Excellent. All right. Either or both. Can this surgical technique be used? We'll just say it can either be used if a person previously had a total knee replacement that is now causing pain. So I guess are either options if someone has already had a total knee replacement that's giving them some pain.
So I would say, so if a painful total knee, there are a number of reasons that can be. We'd certainly have to see you in the office, get some X-rays, examine you, and try to determine what's causing your pain. There can be multiple causes why somebody's having new onset pain, or after a knee replacement, or has had pain since surgery, for years, after a knee replacement. As far as using the technology goes, I do use, when people have partial knee replacements and those need to be converted to full knee replacements, I do use the robot in those procedures. There are some revision techniques out there for the robot, and they're actually actively working on a revision. We refer to this as a revision surgery, where somebody's had a knee replacement and now we need to go back in it and change some things. They are working on applications to use that in the revision setting, but nothing that I'm using right now for a true full knee revision. Although it is something that I'm more than comfortable to take care of. So if that's something that you're dealing with, I'd be happy to see you.
Yeah, I mean, I'd like to say that's exactly right. I mean, if you have a painful knee, you need to come in and be evaluated to find out the cause before deciding what the treatment should be. And both myself and Dr. Porter do revision knee arthroplasty or knee replacements, where sometimes we need to take out the old components and put the new ones in if we find a problem. But again, the first step would be to make an appointment, and so we can determine what's going on.
All right, and we'll make sure we share our phone number so people have that ability to get a hold of us and get scheduled if they would like to consult you on those questions. All right, next question. How painful are the first few days post-op?
Um, so I have, we have made adjustments to my protocol. Specifically, we do, we both use spinal anesthesia and we do blocks, which are anesthetic injections of the nerves around the leg before the surgery, which lasts different periods of time depending on the medications you use. I use a longer acting blocking agent. So my patients get up to 5 days of significant relief after surgery. I also use this medication also intraoperatively during surgery for different portions of the knee. So I have seen a significant reduction in postoperative pain that patients report. I have a form that patients fill out. When I started this process, I made this form so the patients could every day give us a numerical value of how much pain they have. And since I started this protocol, it has really significantly dropped off towards minimal discomfort to none. I have many patients coming in telling me that they really didn't take any narcotic pain medications other than Tylenol and maybe Advil after surgery. And they tell me this at their 2-week visit. And I can see that I can see that their function is significantly better by the graphs that I showed because every mornings I check, I can see that they are moving better, their range of motion is improving. So the pain modalities I'm using have significantly improved our outcomes.
Excellent. Another question on the smart device. Is that an elective procedure or is that part of your standard care, Dr. Magitsky?
Uh, So it is, well, every knee replacement is an elective procedure. Nobody's forced to have a knee replacement. I tell my patients, I don't tell my patients when to have a knee replacement. They tell me. Usually people come in, they get evaluated. Initially, we start, as Dr. Porter said, non-operative care, whether it's therapy, braces, medication, injections. And when those things stop working well, patients come back and say, Doc, I've had enough. You know what I mean? We've been going around this. We're trying. It's worked for a while, but at this point, I'm ready to return to my life. I want the quality of life. I want to not be able, I want to be able to not have to think about the activities I want to do. I want to play with my grandkids. I want to go up the stairs an extra time. So every knee replacement is an elective procedure. Now, the smart knee, that is something we discuss in the office. The one prerequisite to having a smart knee is that you have Wi-Fi access in your home. Most people do, some people don't, but most people do just because the knee communicates from inside the joint via a signal to a little router that connects to your router and then sends the information every single day. The one thing I just want to say that people have always asked me in the office that I didn't address in this talk is this knee does not have a GPS locator. I do not know where you go. I do not follow you around. I only see how your knee is doing. Okay, so don't worry.
That was a
Um,
question. So
yeah,
thank you
good.
for answering
No,
that.
no, no GPS. And if you have trouble, if you're older and you're afraid you won't be able to deal with the technology of hooking up one router to the other router, don't worry. We send out a tech to your house. If you have any trouble, they come and they help you set everything up.
Great, thank you. Dr. Porter, how long do most people take to get back to normal activities with a knee surgery? And should someone do both knees at once or one at a time?
So you're up walking around a few hours after surgery. You don't have a brace. You don't have any restrictions. You can put all of your weight through it. You begin, the first few days to the first few weeks, it differs by patient. You begin with a walker, and over the next few days, transition to a cane. At the 2-week mark, I'd say probably about 50% of my patients aren't using anything at all. As far as getting back to work, I generally tell my patients to anticipate taking about 6 to 8 weeks off. Certainly, if you work from home or have more of a desk job, you could get back a little bit sooner. If it's more manual labor, construction, up and down off your knees for long periods of time during the day, It can stretch out to 3 months before getting back to that, but generally people are getting back into their normal routine in about 6 to 8 weeks.
Excellent. Dr. Magitsky, how long have you been using the Smart Knee? How many patients over how many years? Also, a question on the cost. If you know about Medicare, does it cover the cost of the Smart Knee?
Yes. So I've been using the Smart Knee a little bit less than a year. I have probably somewhere between I haven't looked at the number exactly, but I would imagine somewhere between 75 to 125 patients. I believe the Medicare cost is, I mean, the cost of the implant is part of the overall reimbursement that the hospital gets from the components, so nothing for you to worry about.
Um, so for both of you, how many, well, Dr. Porter, how many Makos do you do on average per week? And then Dr. Magitsky, how many Smart Knees?
I would say 4 to 6 robotic knee replacements a week.
Yeah, I'm in about the same range. I mean, I do 3 to 4 cases a day, 2 days a week. So, some of my cases are hips. And although the hip, smart hip is coming out, it's not on the market yet, but it will be available soon in a similar kind of technology. So somewhere on the order of between, I would say also 3 to 5 per week, just because my other cases are hips.
Dr. Magitsky, will the Smart Knee battery interfere with any other medical testing equipment after the surgery, for example, an MRI?
So it's not the battery itself, it's the metal in components. So any knee replacement components, they are made out of metal, different kinds of metals, but they're still metals, or will interfere with an MRI image of that general area. So if you had an implant in the knee, then the MRI of the knee will not be great at all. But an MRI of the hip or any other location away from that location should be fine.
Let's have you both answer this one. So this individual has put off knee replacement for a while, but knows they need it. How much notice would they need to give you in working with your team so that they could have their surgery performed at a specific time of year?
So
The
I'll
f-
say
So I
I'm
guess like how far out are you
yeah,
booking? When would they need to plan it with you?
I'm generally booking about 3 to 6 weeks out, and or can find some availability within that time. And I would say I don't often book joint replacements sooner than that, just because there is a workup. We get some lab work and we have you meet with your primary care physician. We have you meet with any specialist you may have if you see a cardiologist or a pulmonologist to make sure you're optimized for surgery. So we do need a couple weeks to get that all in order. But I'm probably booking it. It varies depending on the time of year, somewhere between 3 to 6 weeks out.
yeah, I mean, I would say I'm exactly in the same situation because we work in the same healthcare system, so we have the same limitations. The only thing I would say is that, occasionally there are cancellations. For whatever reason, health, family, personal, people cancel out and a spot opens up. So you can always call our offices and ask to speak with one of our surgical bookers and find out when the first available is, and they can let you know.
Okay. So regarding the battery for the Smart Knee, does it
Yep.
eventually stop working? What type of battery is it, and how do you make sure the ingredients do not contaminate the knee or your body?
Fair question. So this is a true and try technology. This is a battery from pacemakers. Okay, this has been implanted in people for multiple decades, and all the bugs have been pretty much worked out. The battery does not leak. The battery takes years to stop working, but by that point, it doesn't really have effect in your recovery because the most critical period of time is during those 6 weeks when I can see whether you are above the curve, at the curve, or behind the curve, which allows me to, what I mean, do something about it if you're behind the curve and not waste the time until you show up to the office and say, Doc, I've been miserable, or I can see that your range of motion is not there. So do not worry about the battery. It's been tested, tried and true, and it works perfectly, and it never needs to come out. Nothing needs to be done.
Okay. What anesthesia options are available for a total knee replacement? General, nerve block, and then what would pain management look like after surgery?
So we're both fairly similar on this. So I generally, the vast majority of my patients get spinal anesthesia. So you're not intubated, you don't have a tube down your throat, you're not on a breathing machine, but we do give you some medication. You take a nice nap, you're not going to remember any part of the procedure whatsoever. Both of us have our patients receive blocks preoperatively, for pain control postoperatively. During surgery, again, I think we both do the same things here, where you use a local anesthetic that we infiltrate in some of the tissues here to further help to try and reduce pain postoperatively. And then after surgery, I use a combination of an anti-inflammatory medication, Tylenol, to hopefully control most of the pain. But I do generally give patients a narcotic prescription, especially for those first few days, first few weeks, where with some patients are experiencing a little bit more pain.
Yeah, I mean, I like with that. That's exactly right. I mean, I think the postoperative protocols are fairly standardized across, I mean, joint replacement surgeons, just because we all tend to, want our patients to have the best experience, and we all kind of gravitate to things that have been shown to work through multiple studies, and we do literature reviews, and we can see what works. And as such, our practices kind of evolve to involve new things. As Dr. Porter said, spinal anesthesia is our primary anesthetic choice, unless you have, significant spinal pathology or history of instrumentation in the back, and the anesthesiologist just can't, what I mean, get the needle in to do the anesthesia. But it's significantly better because it has less effects on your heart. Doesn't give you the kind of the brain fog after surgery from general anesthesia, and those. After surgery, we use local anesthetic blocks in the leg. And again, we try to minimize narcotics, and we have been able to decrease our narcotics as time has gone over the last couple of years, just because we use the other modalities. If you need it, you need it. We don't leave you hanging. You know what I mean? You call and you tell us you need it, and we will, call in a prescription. We may have you come to the office in the next couple of days to make sure things are okay. But you are never without coverage for your discomfort.
All right, so we have some questions similar in nature, related to, would Dr. Porter use the smart knee? Would Dr. Magitsky use the robot? How does a patient or potential patient decide which one of you might be the best fit for them?
I think the best way is to come in and to talk to us. At least that's my view of it. Talk to us, see, I mean, what questions you have and how we answer them, whether it's to your liking, whether you kind of feel, vibe with the answers and with the surgeon. We also have doctors, and we've had doctors who we didn't have a connection to, and we have doctors that we've felt a connection to. So from my perspective, it's all about the personal relationship you have with your patient and your doctor.
Yeah, but I would add too, we both, a lot of our postoperative protocols, preoperative, what goes into, the anesthesia is very similar, but we use different components, just, and it's stylistic what we feel more comfortable with. Not that one is necessarily better than the other. It just different options and what we use consistently in our practices.
Come in and talk to us. Ask questions. We'll give you answers.
All right, thank you, Dr. Magitsky. So next is from a 73-year-old. They had a meniscus repair on their left knee in 2019. That left knee seems stable, but their right knee, they're experiencing similar pain. Looks like they had some PT a couple years ago in 2004. Wondering if you would suggest a meniscus repair in that knee before a knee replacement.
It is. Let me see. I can, without seeing you and evaluating you, putting our hands on you, you know what I mean? Maybe getting an X-ray or an MRI, depending on what we feel. It's really, very difficult to tell you what our recommendation would be It's like telling a mechanic, my car makes a brrr noise. How are you going to fix it? Until you bring the car in, we won't know.
Yeah, I would say give us a call, come in and so we can take a look and evaluate you, get some x-rays, and can come up with some more answers for you at that time. But it's something where we really do have to see you in person and get some imaging to determine what's going on because there can be multiple causes, for
Yeah, definitely with all the virtual medicine orthopedics, it's tough because you need that imaging and you need to see that patient in person.
And
So,
our hands, we need to
yeah.
get our hands on you to push and prod and figure it out.
Figure out where the pain is coming from.
Right. Sometimes, and I was just going to say, over my 20 years, I've had a innumerable amount of patients who have come in, and said, my doc, my knee's killing me. My knee's killing me. I can't do it. And then, I evaluate them and we get an x-ray of the hip and it's a destroyed arthritic hip and the knee looks fine. There's a concept called referred pain. And, you can have terrible knee pain from an arthritic hip. And unless you come in and be evaluated, you won't know. That's why we are, spent many, many decades training, learning to be able to help.
All right, we're going to move on to a PT question. This individual has heard maybe instead of a set 2-week home PT, it is better to get the patient into outpatient PT sooner. How do you guys use outpatient PT?
I'd say so. Generally, for the first 2 weeks, we're doing therapy in the house. Sometimes it's a week, and patients transition a little bit sooner. With this, especially just the first week, it's really just working on some gentle range of motion exercises, which can be done in the home and saves you the trouble of having to get in and out of a car, walk up the entrance to the physical therapy office. There isn't a lot more they can accomplish in that, at least in that first week in the physical therapy office as opposed to in the home. Certainly after that, when we start working, more aggressively on strengthening and some other exercises, there are certainly more equipment and things that they can do in the facility as opposed to in the home.
Completely agree.
Okay. This attendee has a comment for us. So they did a PRP injection for an arthritic knee out of pocket, and they didn't find it really gave them significant relief. Subsequently, had a successful total knee replacement and have indicated that their research shows that PRP might work better on shoulders than knees.
I mean, we're talking about a difference between a weight-bearing and a non-weight-bearing joint. So I think that's really a very important first thing to understand.
Hmm.
And again, the fundamental principle I think folks have to understand is inflammation. Inflammation is a fundamental process of our bodies. Unfortunately, it gets more as we get older, and that becomes the source of all our aches and pains. Inflammation is part of the healing process, but it's also part of the disease process. And we use whatever works. If I give you shots of cortisone or anti-inflammatory medications or PRP and you feel better, then we don't need to move any further. As I often tell my patients, I can't make you better than no pain. And if our treatment has solved the problem before the knee replacement, then that's fantastic. We'll keep going that way for as long as it keeps working.
All right, next question is on cortisone shots. So someone is currently getting cortisone shots to manage their pain. They're curious how long would they need to wait after a shot before they could go ahead with a knee replacement?
3 months. Otherwise, the risk of infection is significantly increased.
Okay, great. Thank you, Dr. Porter. Are there age-related factors to a total knee replacement, as in related to recovery time and final recovery results? So maybe does age matter? If you're older or younger, do you have a better outcome?
So I would say there's two different ages. There's a physiologic age and there's chronologic age. And chronologic age is simply how long, you've been on this earth. And the physiologic age is what kind of condition you're in. The better your muscle mass, the better your flexibility, the better condition you're in, the easier your recovery is going to be.
agree.
True.
Yeah, very well said.
All right, maybe related, this attendee has had people tell them who've had a knee replacement, do it early, don't wait. Maybe aligned with that.
This is not a sale at a store. Get in there and buy everything. Honestly, again, I hate to kind of beat the dead horse, but come in, be evaluated. We will make the best recommendation that we can for you and your condition. Okay, we will tell you the right things and in the order of the right things to do. Yes, there are people who wait too long. And there are occasionally people who want to jump into it too early. Unfortunately, the people who wait too long is a much bigger group, but that's why you come to see a doctor and get information and ask questions, and you can always get a second opinion. You're never wrong about getting more information. So my answer is be evaluated not only by your x-rays, but also by your symptoms and by your functionality. And based on all of those factors together is how the right decision is made.
Yeah, and I would echo that sentiment. I would say, neither Dr. Magitsky or myself would ever push anybody into surgery, right? I'm a big proponent of shared decision making, kind of laying out all the options for you and determining what's best for you, as a patient, as well as what's best for you at this time in your life, right? There is certainly a recovery that's involved in this, so it needs to be, a time in your life where you can dedicate the time to recovering from this so that you do ultimately have a good outcome. I will say though, what I hear most commonly is, I wish I did this sooner.
Right. Absolutely.
All right. Getting to our final questions. We have an attendee concerned about infection. Have many of our patients had post-operative infections?
It's okay, Drew. I'll take this one first. We can answer it. Yeah. So, fortunately, no. The answer is no. Not a lot of our patients get infections. Do some people get infections? Absolutely. Complications, whatever they may be, and infection is one of those complications, is the reality of surgery. If a surgeon tells you they have no complications, I would walk away and go see somebody else. Our complication rates, infection rates are at the level or below national averages, which is somewhere on the order between 2 to 4%. So out of 100 patients, 2 to 3 patients may develop a problem. But again, there's different types of infections. There's early, there's late, and we know how to take care of all of it and do when they arise.
Agreed.
True.
Yep.
Go ahead. Uh, Dr. Magitsky, I know we're getting right at time. I want to make sure I leave time to give out our phone number. Should the data from the Smart Knee show poor results? So I guess if someone's having a poor recovery, what is done to correct that situation?
Okay. Is it possible to go back a couple of slides on the left? One more. Okay, so if you look at this map, the four graphs on the left is from one patient, and the four graphs on the right is from another. And what you can see is here on the bottom is the weeks, and on the x-axis are the weeks, and the y-axis is range of motion and number of steps. The patient on the left, you can see they are in the upper portions of the yellow bands. The yellow bands are like what's called the normalized graphs, meaning how 1,000 other patients are doing in this level. And you can see that the patient on the left, their black lines of range of motion, the number of steps is tracking really well. This is a patient that nothing needs to be done for. This patient is doing well. They're happy. And I know when they come into the first post-operative visit, they'll be smiling. The patient on the right, you can see it's the red, not the green. You can see how they're in the bottom of those yellow graphs. Okay, this patient is not taking enough steps. They don't have enough range of motion. And this is really the key point of my talk, and that is the fact that I can see that day to day allows me the ability to do something about it before waiting until they come in and then find out that they haven't, performed as well as I would want them to. it allows me to reach out to them, talk to them, find out what's happening. Have they been sick with the flu and they just haven't been getting around? Or is it their knees hot and swollen, painful, and they can't really get around or do the therapy? If it's if it's a flu, it's understandable. You get over the flu and then you restart your recovery. But if it's something having to do with the knee itself, then I can talk to the therapist that's coming to your house. I can tell them about what I think is going on and how to change up the physical therapy plan, what exercises they should add or take away so as not to aggravate your knee. Um, uh, the nursing staff that comes into your office, I communicate with them to have them give me their clinical opinion about whether there's something going on wrong in their opinion. And in that case, I will have you come to the office before the first follow-up appointment so I can take a look and do all the things that are necessary to make sure we're not falling behind the eight ball in terms of time.
All right.
Thank
PT before surgery. Do you guys suggest that?
Can't hurt. I have some patients that are interested in doing it, some patients that aren't. I think, physical therapy is never going to be a detriment, and especially in patients that are maybe a little less active at baseline, certainly can be a great help.
Yeah,
And
absolutely agree. My opinion is that the more muscle mass you have, the stronger your extremities are, the better your muscle condition, the easier your recovery will be. So I'm all pro for that.
awesome. So our final question has been a kind of one that's a good problem to have, which is both of you seem to have great approaches. And so for that patient trying to make that decision, whether they might want robotic or they want the IQ, how to help them decide. Maybe consult with their PCP. And do you have any other suggestions for the patient who's trying to determine what approach is best for them?
I think just come in and meet with us. But you can meet with both of us if you want and decide, which route you want to go. There is certainly no hard feelings if come see me and then decide you want to have surgery with Dr. Magitsky or vice versa. We're here to help our patients and help our community. So come in, speak with us, and we can help guide you to what's best for you.
Yeah, absolutely. I mean, I have numerous patients that come in. We discuss their problem, we discuss the issues, the treatments. They're given opportunity to ask questions, all of which are answered before they leave. And when they leave, they say, "Okay, doc, I need to think about it." And that's a patient that's thoughtful, intelligent. I kind of like that kind of a patient, because then I know if they come back and decide to go, what I mean, forward, then they have reasonable expectations. So again, as Dr. Porter said, you should come in, talk to one of us, make a different appointment, talk to another of us, see what makes more sense or what where you feel the affinity for.
Excellent. Well, thank you both. That was really very insightful. And thank you to all of the attendees and your excellent questions. And as we said, if you would like to visit or make an appointment with either one of our fabulous physicians, Dr. Porter or Dr. Magitsky, our phone number is 508-342-1103. So stay healthy. And the poll just popped up. Okay. Well, thank you all for attending and have a great night.
Thank you, everybody. Have a great night.
Thank you, everyone.